me to meet that. Don't mess with threes unless you're
Sure.
good at it. This year will be building on that. Kind of just it'll be a run back through all the first year stuff. Getting more simplified with the stuff tracings, like what actually matters, rather than like here's like all like 28 points. Like now we just need like these 12 or whatever. So it'll be some stuff like that, simplification, and then it'll just be going more in depth into what we need to know, or if we have cases, presenting those cases and working through different ways to do them.
Great.
Sammy brought her son in today, so I might be able to do him too for a case.
Great. What does he have for an occlusion?
He's class 2 with an overbite. He's probably like 50% overbite. Looking at him real quick today.
Yeah, what's interesting is that particular malocclusion is so damn common because of the airway compromise.
Yeah.
So if we understand nasal obstructions and we follow craniofacial development, the end story is often the class 2 deep overbite.
Yeah. And I had Regan, got to show Regan something, which is kind of fun. He was all excited.
Regan excited?
Oh, yeah, he did never do that.
You could take him to Burger King. He'd say these are the best French fries I've ever had.
No, I had him, for those of you guys who haven't had to do it before, it's just a quick trick. If you have a 35 millimeter cotton roll, you can get an idea of how wide the intermolar distance is from 3 to 14, lingual to lingual. And if the cotton roll doesn't fit, or if it extends over the occlusal surfaces of those teeth, then they're too narrow. So I just had him do that today because he was working on them. He just had me swinging to take a quick peek. But the cotton roll like overlaps his teeth, so he's too narrow.
At what age would we expect that palatal width to be locked in?
You mean not be able to move it like the normal way? You mean? Or
yeah. So if we're going to be measuring,
measuring
intermolar widths, I don't know at what point can we say this is craniofacial development has ended. I mean, we know that craniofacial growth occurs throughout the entire adult life. We've learned that, but there's definitely a point at which it tends to diminish.
He's 10. Probably still okay to do something for him. I think it's basically somewhere like around 11, 12. For males anyway, I'm gonna get that much. I think is what we talked about last year.
Yeah, I don't know if anybody's ever heard of orthotane. It's I think Embrace or MyoBrace is a more up-to-date version of these concepts. Orthotane was a series of pre-made bite guards that kids would bite into based upon their age. So the dentist would make some measurements of a 6-year-old, and then they would order a set of trays, and those trays would help grow the maxilla. So it was like having pre-made Invisalign trays for a 6-year-old. But MyoBrace, and I'm very much speaking out of turn from the concept. I haven't actually used these. This is just from my understanding. So if anybody here is more adept at these concepts, feel free to chime in. But the point I bring this up, orthotane used to end their trays around ages 11 and 12, which is what you were saying. Craniofacial development, as far as from a dental perspective, has more or less reached its peak. So, yeah, measuring that intermolar width is super important. We do that with adults. Luke and I have a top secret invention behind the scenes, which is basically a 3D printer with a bunch of millimeters on it, where we don't have to use a cotton roll, we just use a ruler to screen for patients with intermolar width. But it's a screening tool. You just use the cotton roll and get a sense of how big is their palate. Is their palate big enough to support the presence of the tongue? And if they're not, are they somebody who has airway issues? And if so, you can have the conversation. You don't have a wide enough palate, therefore you're at higher risk for sleep issues. So we can use it as a screening tool. We can use it as a diagnostic tool. We can also use it as a tool for risk analysis for younger kids that they're likely to develop issues because they're not developing the way they should. So it's another tool in the toolbox. Yeah, thank you for sharing, Luke.
Oh yeah,
Yeah, I can't wait to see some braces on some kids this year. I have
be cool.
I have several kids in my family that would love to take advantage of it.
Do it.
Yes. All right. Well, welcome everybody. So tonight we're going to go over handpieces. And I know that might seem a little bit rudimentary, but I think if I do a good job of describing why I think it's important for seasoned dentists to be going over handpieces, hopefully I'll do a good job of articulating why I think it's relevant to a clinician at any point in the game. And then I threw in hand grenades, partly because I can't help myself but try to pretend to be clever with my titles. You'll see what I'm talking about when I get to that part of the conversation. So here we have directions from 3M. Nothing specific about 3M, nothing specific about Softflex discs, but we can see here 10,000 RPM. I would presume that we've all seen advertisements where companies will have specific directions on the speed at which that rotating disc or that rotating burr should be turning at in order to achieve clinical efficiency, reduce risk of untoward events such as pulpal overheating of pulpal tissue, so on and so forth. So it's important for us to know that certain products that we use have certain speed limits or ideal speeds at which they should spin. Well, I spent much of my career not understanding what am I really spinning at. And again, if this was training that you had in your dental school education, bear with us for just a little bit. I think this is something that is highly misunderstood in the industry. Here I took another screenshot from Meisinger, just making the point that they have recommended speeds at which these things should be rotating. I just know for a fact, because I was that person, that we tend to do dentistry not thinking about how fast this thing should spin. And judging from how quickly they wear out in my practice, I know some associates, I don't know who they are, spin these too fast because they wear down a lot faster than they're meant to be. Not trying to single anybody out, but just make the point that this stuff is important to understand. I did a quick PubMed search and just found that RPMs are very much part of the literature. So this particular article had to do with RPMs and different systems when it comes to adjusting zirconia. The point is there's a range here. And clinically, I don't think we know where we are at all. I know this because I was that person. It's important. Here we have temperatures that were measured based upon different tools that were used, but they measured them at different RPMs. So there's a clinical difference with temperature. Again, this is with zirconia, but you can draw the parallel that when we use certain instruments on teeth, that this heat change will affect intrapulpal temperatures, which up to a certain degree can cause issues. Yes, we use water when we prep teeth, but how much water? How fast are they spinning? Is our burr dull or not? These are all important questions, but I wanted to focus on speed today. So, how do I know how fast I'm going? Here is an electric handpiece. Anybody want to chime in about what all these numbers mean?
I actually have no idea.
Yes. Luke, it's almost like I paid you $20 to say that. All right. Well, everything on the right means nothing. NSK is a company. Timax is their particular brand of handpieces that are made of titanium. Max, just their line. The Z95L. L is for long. They have a short version of this. None of that really matters. It's the 1 to 5 that we want to pay attention to. Likewise, we have a bunch of different handpieces. So we've all asked an assistant to go get a handpiece, and they come back with something that looks similar, but it's not exactly the same thing. To the unastute observer, they may not know what this means here, and they put the handpiece on, and then they continue working. maybe no harm, no foul, but maybe there is a problem with that particular handpiece in the job that you're trying to do. We'll come back to this. So Adec delivery unit, this one's a little different than the one that we have, but on the readout, we tend to look at the RPMs that are coming from the handpiece, or coming from the motor, not the handpiece. So the motor has a deliverable amount of RPMs that it's giving to the handpiece, but that's not necessarily what's coming out on the burr. So to put this in diagrammatic form, we have an Adec unit. Let's say, for example, we select 20,000 RPMs. Again, this is what the motor is spinning at. But then we have all these different handpieces. And the moral of the story is that these ratios here are either reduction ratios or multiplication ratios that will change the RPM that's coming out of the unit to what's coming out in the handpiece. And there's all kinds of physics reasons why that happens. Much of it has to do with torque. But much of the time when we're using high-speed handpieces, we want a multiplication. So we'll use something like a 1 to 5. So the 1 to 5 means for every turn that the motor is doing, the handpiece is adding 5, a multiplication of 5. So it's a force, not a force multiplier, but a speed multiplier. Conversely, if you see the larger number in the beginning, that's a reduction handpiece. This is an endo handpiece. Endo handpieces range from a 10 to 1 all the way to a 20 to 1. Implant handpieces tend to be a reduction handpiece, because when we reduce speed, with an electric handpiece, we actually increase torque and we increase control. So there's certain purposes of these handpieces based upon their gear alteration or gear reduction or gear multiplication. There's different gears in here that allow the burr to spin at a different rate than what the motor is telling it to do. So for example, the max that you'll see with most commercially produced dental handpieces is 100,000 RPM. That's what we run 90% of the time using a 1 to 5 ratio. Where did I get the 100,000? 20,000 multiplied by 5 is 100,000. Down here we can see 5 to 1 and 1 to 5 are examples of reduction and multiplication based upon the job at hand. Now this one down here, the ratio is right there. 4 to 1 is a common prophy handpiece. So hygienists actually typically go around, that would be 5,000 RPM. 5,000 RPM with prophy paste and pumice seems to be the proper speed. Somebody figured this out a long time ago, and the industries go with it. But I think it's important for us to know that we're using these spinning tools, and the spinning rate has a clinical relevance. So this topic came up with one of the associates recently, and I thought this was important to go over because there was little understanding with what these ratios actually meant. Now, the topic for today, and very seldomly with our Monday night sessions, is rarely surgery. This comes into play quite a bit when we start talking about osteotomy creation with dental implant drills. They'll give you an RPM, but you really have to understand what these reductions are or multiplications in order to understand how much is spinning, because there's really no more important relevancy with this concept than implant dentistry. So that's kind of where the topic came from, but it's relevant to restorative dentistry. Anybody have any questions there? Does that make sense? Luke, do you feel empowered now?
Yeah, I got it. Thank you.
So this came from a website. I was doing a little bit of research on handpieces. I don't really want to dive into the weeds too much about electric versus air-driven as far as how they run, but it's important to know that the old air-driven handpieces, we looked a lot at the PSI, or how much pressure was being delivered to cause the rotation of the burr and the handpiece. Low-speed handpieces are designed to handle much more air pressure than high-speed. That's not relevant. 40 PSI. There are still dental offices out there where you control your RPM by controlling the PSI. Dr. Labonte knows that because he works up at Naples, and before last week, the unit that we had there, it read in PSIs and not RPMs. We've since updated that. We talked about this a little bit earlier. Speed reducing gears allow the handpiece to generate significantly more torque. Torque is very important when it comes to doing the job that we need to do with such hard surfaces, such as enamel. The hygienist handpieces at 5,000. Endodontic and implant motors tend to use reduction handpieces so that we can get down to 1,500 and generating very high levels of torque as a result. So one might ask, why not just have one handpiece and just control everything? The gears, it's kind of like the gears of a bike. When you have certain reduction and amplification, you actually get more and less power that comes out of it. So that's the point that they're trying to make here. A little bit of an aside. This is a electric latch angle handpiece. Most office design consultants will often recommend that you do an electric handpiece for your high speed and then air driven for slow speed or latch angle. I don't like using slow speed, but latch angle. That's a way to save on the cost of equipment because the tubing that's used to outfit a dental unit is very expensive when you hook up electric. But if for whatever reason you want to use very, very high torque, precise speed latch angles, you want to get exactly 10,000 RPM because that's what the manufacturer said. You want to know exactly what you're doing to that really nice restoration on number 9. This is a way you can do that. With the conventional air-driven handpieces, which 99% of us are used to using, I don't know how to tell. There's really no way to tell exactly how fast it's spinning. But for those of you who work in the practice, what you can do is, we have one of these. I bought one for the following purpose. I put it on the electric handpiece. I looked at the gear reduction ratio, and then I spun it at 10,000, did the math, and I looked at it and I said, okay, that's 10,000. I did that a couple times over the course of a year. Now, when I use conventional latch angles, I know exactly about, well, I say exactly, I know about how much that should be spinning, and I'll control the rheostat to give me that RPM. If you're using polishers at 40,000 RPM, but they come recommended to be used at 10,000, they're going to wear out very fast. You're going to waste money. But more importantly, they don't work as well. But we don't know that because we've never necessarily compared clinical outcomes between different RPMs. Anybody ever use this?
I just used it today, but yeah, I've used it a bunch of times.
Yeah. What do you use it for?
Actually, today I used the polished composites at 10,000 RPMs on I added an Ove Pontics to a bridge.
Nice.
After extraction. And it was kind of cool because with that one, because I know it's at the right speed, I was watching I zoomed it like 5 times. So I was watching it like smooth out all the lines and the composite as I was doing it. It's actually pretty awesome.
What were you using for a polisher? The Softflex discs or actually you like those Shofu ones?
Yeah, I like the gear looking ones.
Yeah. Yeah, they all work, but you were able to see a higher degree of polishability when you were running at the proper RPMs.
Oh, definitely. Yeah.
I really didn't set Luke up to share this. That's great.
No, I haven't talked to you all day. It's just funny.
Yeah. Electric latch angle handpieces.
We use them routinely too, just for Carrie's excavation or polishing at the end. I really like it.
Yeah. I mean, so Mark, you use it for Carrie's excavation. Do you find you get a lot less chatter?
A lot less what?
Chatter. So
oh yeah,
bumpiness
a lot less of that. The nice part, which I don't have to use often, but you can also turn the air exhaust off. So for whatever reason, if it is a real sensitive tooth or you didn't quite get your anesthetic or you're trying to do it with no anesthetic, tends to have a less irritation. Or if you're polishing someone's teeth,
yep,
and they're really sensitive to air everywhere, it's helpful to not have that exhaust coming out.
Great. So do you guys use these exclusively, or do you have them in situations where you just wanted to use them?
We use it exclusively. We did an expansion a couple of years ago and set it up with an Adec unit and did electric everything.
Great. Yeah, it's something we might head towards. We've had it for a while. I'm glad to hear Luke was using it. Knowing Luke used it, I think we're more likely to consider the cost-benefit analysis. But I agree with you, Mark. It's a different experience for the patient. We're going to talk about that in a moment.
I do like that you can add water to it. I know he likes that you can set the air off, but the fact that you can polish or add water or rinse things out at the same time is so much easier than having the assistant try to guess when you're on the DB of number 15.
Right.
So, sorry, to clarify, you have just this, you don't have, do you do mostly electric handpieces or mostly air driven, or you have both, or this is the only one you have?
So this is the only motor we have. We actually use something like this for the bulk of our slow speed, which is probably what you're used to. 99% of the dental community, except for Wisconsin, uses these. But I agree with Mark that upgrading the entire practice to something like this is definitely something worth considering. When I was building the office, it was, every line item was super expensive. It's like, okay, what do we need and what is nice? This is something that's nice. You don't need this, but it's definitely a better patient experience. It's a better clinical experience. Plus, you get to really know what your RPMs are as you're doing restorative dentistry.
What we ended up doing for ours too is, so we have the high-speed line and the slow-speed line, which we use this motor. So on that Adec unit, you can set all the programmed RPMs for each.
Yep.
So I find that my straight handpiece for acrylic burs, I usually run at very similar RPM sometime as this. So I just have it set to 2005, 2010, and 20.
Great.
And that way I just pop this off, put the straight handpiece on, and it's easy to bounce between them.
Okay, so you guys have one motor tubing, and you switch between the two? Or do you have
for my slow speed line? So I switch out the latch grip.
Yep.
And the straight handpiece for the acrylic burs or Emax polishing burs.
Gotcha. Yeah, that's
and then we can also put on the Endo motors.
Yep.
It works really well on one of the ops. I haven't gotten mine to work really well. I feel like mine over torqued, and it's supposed to have feedback in it. But I've sheared some burs before, and
yeah, that's never
went back to the old motor after.
Never a comfortable feeling.
No.
Yeah, we use Wave 1, which is reciprocating. So although in theory could use the Adec unit, I'm glad you shared that feedback because that's something I've always been concerned about. Adec's not a endo company. They just created.
At least when we set it up, we could not put the Wave 1 reciprocating on our cart.
Yeah, I think it's still not available. So we have the ProMark external unit that we have to bring in. But it'd be great if they offered that. If they provided an upgrade, I would totally do that. If we could get those Adec delivery units to actually have more ports. When I went out to Adec, I was like, yeah, I'm looking for 8 ports. I drew on a napkin on the plane ride over all of the ports that I wanted, and they laughed at me. They're like, no, we only offer 5. You have to decide which ones you want. And I was like, but I want a Cavitron everywhere. I want electric this and electric that. So we're a little bit hindered in what we can do, but you can switch things out. But I think what you were saying, having this be a main player in the restorative arsenal is definitely something worth considering. Yeah. Well, when I put this slide in, I didn't think we were going to spend that much time on it. I'm glad this little image provoked so much discussion. It's these small things we don't talk about. We can go to spear courses, we can go to whatever. They're not talking about this. They just assume that the average dentist knows this. But I go to conferences and I'll have a handpiece and I'll be talking, and it's like, and again, I was that person for many years. I had no idea. So these are why I think it's important for us to bring this stuff up. Quickly, if you have these versions, it's very important to make sure that's tight. These tend to loosen a lot. If that's loose, it may not be perceptible to you, but I promise you this whole thing is rattling and the patient will feel it. So when we use flow speeds, it's important for us to know that this is pretty rudimentary equipment. This isn't too far from the previous generations of pedal operated instruments. This is just a rotating carbide burr with very low speed. So to the patient, the experience is important. So just know when you're using your latch angle or your slow speeds, understanding this stuff will help translate to a better experience for the patient. So I put the rheostat here. I wanted to go over a concept that I think has some relevancy. To articulate it, I drew a X and Y graph. And here we have the speed of handpiece. This is not necessarily specific to slow speed or high speed. It's just, in general, speed of handpiece. Does anybody want to guess what the left x-axis is?
The pressure on the rheostat pedal,
You're getting there.
position on the pedal.
You're getting there. You're in the right ballpark. This is a clue. So anybody know what this is?
Is that a foot pedal unit? What
Yeah.
is that?
Yeah,
Oh God.
So, back in the early days, this is how they created the energy to rotate the burr. They would pump that pedal and it would essentially spin at the handpiece. Well, what we have today isn't really that different when it comes to the slower speeds. So 1875, it says here 1860. Anyway, 1800, some guy named Dr. Green came out with the earliest version of the modern dental handpiece. So going back to this here, the reason why I bring up the historical nature to it is because patients remember the bumpiness to the dental experience. So it's very well known in the world of handpieces that the speed at which the burr rotates, the less bumpy it gets for the patient. Obviously, the burr grit has a lot to do with it, carbides versus diamonds. This is just very general to make a point. The faster the speed of the burr, the less the perception of the patient. So I share this because I would encourage people to think of the following. Use full speed at all times, and instead of using the rheostat and like tapping on the rheostat, which is what a lot of us were taught in dental school, using the rheostat as a variable, my suggestion is to just step down on it and use your hand, not your feet, to control the interaction with the handpiece. And if you do that, your patients might thank you. Does this make any sense to people? Have people ever noticed that at slower speeds, things tend to get bumpier? I share this because I've had, 7 dentists work on me since my residency, doing various things. 3 of them worked on slow speeds, and it was pretty uncomfortable. I'm a dentist, so I knew what they were doing. I think as a patient, they might not know that you're doing something, I don't want to say incorrectly, but there is a better way. Use the rheostat to full speed. So where this came from, this is my theory, and I would love to hear what you guys have to say. Air-driven handpieces, which were the most common before the age of electric handpieces, these are, and to this day, still the most common dental handpieces found at dental schools because they're much less costly to buy, much less costly to repair. Unfortunately, there's no torque control, so that's why we have to do something called feathering, which requires a different technique called feathering. Electric handpieces, so for those of us who have tried both, this is I don't want to say a better handpiece. There are people that say air-driven provide a different feel. I think that's just more because that's what they're used to. I can't imagine ever relying on an air-driven handpiece to do a crown prep. That would just drive me nuts. Electric are very efficient because there's constant torque control because of the electric nature to it. So this does not require speeds lower than maximum. So we don't need to do feathering. What I have found is people come out of dental school learning how to do dentistry with an air-driven handpiece, and then they're given an electric, and they continue to do the same things that they were taught how to do, which is to use the feathering technique with the rheostat. You don't need to do that with electric. And I'll walk by operatories, and I still hear people doing it. There's still that, pressing down, lifting up, pressing down, lifting up, and that's just from us learning on an air-driven handpiece that's what we should be doing. I would advocate for constant speed. You can control the speed on the Adec unit, but you don't necessarily need to use the rheostat. Any thoughts here? Was this obvious?
I'd say that's pretty consistent with how we do it. Like the times that I'll change a speed on a crown prep is because I'm switching a burr to a polishing burr, but I'm still maxing it out at that lower RPM.
Great.
Rather than just try to do half pressure and go. Just makes it easier.
Yeah, is that something that you learned along the way? Did somebody share it with you? You know, I definitely learned this from somewhere. I don't know where, but
Don't remember where, but I know for finishing the crown margins, probably at a Sarah course of just, hey, here's the fine grit burr to polish your margins at the very end. Just easier at a slower RPM.
when you use the max RPM, are you literally just pressing down on the foot pedal and you're just letting the burr do its work, and you're using your hand to control?
During the prep, it's just foot all the way down.
Yeah.
Use full RPMs.
Did you find, and maybe you were trained to do this, but I've had this conversation with people, and I think to, brain power allocation. If our brain's having to focus on how much we're pressing on the rheostat and where our hand is, there's a utilization of resources issue there. In other words, our brain has to think about doing two different things, even though part of it's subconscious to a degree. When I started doing this, I felt like I could breathe better when I was doing my preps because my brain was focused purely on my hand. And I use the analogy of golf. When I putt, I'm looking at the line and I'm thinking about the speed. And when I separated those two into two different compartments, my putting went through the roof. And I think of this as the same thing, which is if you're using the rheostat as a variable throughout the technique, whatever you're doing, crown prep is a great example, you're probably not maximizing the efficiency, but you're also making it more stressful. Is anybody still feathering?
I am definitely guilty of the feathering with the electric. I think you called me out on it a few times, and you told me you would explain why, and here we are.
I did say that? Oh.
Yeah, you said we'll get into it at some point, but
here we are.
Never heard the second half of it.
Yeah, so were you guys taught with air driven?
We had both. I, for whatever reason, just kind of leaned toward the electric from the start, so that's what I used primarily for everything. And I was like the anomaly. I had to request an electric handpiece for our board exam because that's all I had ever done.
Sure.
Because they were only going to give air driven to everyone, and I was like, I don't think I should take a board exam with a handpiece I've never used.
Yeah. You want to be comfortable in that environment. Yeah, Chad. Let me know how this goes.
Yeah.
What was that, Mark?
That would just be a really rough exam.
Yeah.
I go from that to an air driven.
I was nervous. I had to smooth talk the CSR people to put one off to the side for me.
All right. Anything with handpieces? Pretty boring topic that I hope there was a little bit of value for at least one
I have
person.
a random question, actually. In our oral surgery clinic in school, we had the rear exhaust handpieces for surgical extractions.
Yep.
Or at least that's what the interns and the residents and stuff would use to help us. But I don't think I've seen those, or maybe they're just a lot better designed now than the ones we had there. Are those common practice to use rear exhaust
Yes.
handpieces for? Okay.
Yep. With air turbine handpieces, you're going to see, the rear exhaust is more noticeable from the standpoint that it's air driving the handpiece, whereas electric, that's not the case.
Okay.
Now, granted,
So with electric,
there's still chip air in the electric. So chip air is the air that's used to make the water mist.
Yeah.
That's what you can turn off on an electric handpiece.
Okay.
On the air-driven, there's also chip air, but there's also the air coming through the turbines that are, essentially that's what's turning the gears. That's where the rear exhaust comes into play. So you're probably not used to seeing an electric handpiece with rear exhaust because you just turn off the chip air.
Gotcha. So for areas where you might be concerned of the air emphysema that can occur, electric handpiece, the risk is very, very low.
I think the risk is very low with air-driven handpieces without rear entry, and I say that because people have done the studies. That's actually, I don't know if it's happened. I'm not saying it's not going to happen. I'm not advocating because I'm not qualified to opine on this at all. Other than, I know many dentists that practiced their entire career without ever buying a surgical handpiece, and they were doing tori removal and sinus lifts and all kinds of crazy stuff. They never had any issues.
I feel like my school like beat it into us.
Well,
Like
mine did too.
This will happen if you use an air-driven handpiece.
Yeah, I mean,
I'm more concerned about the oil coming out into the open site.
yeah. Mark, is there a
Interesting.
difference between oils between the air-driven electric or just oils in general?
Just oils in general. So,
Yeah.
I mean, I prefer not to use my electric handpiece. I'd rather do a surgical if I'm troughing bone, but I'll just make sure it's been running for a while, turn air and water off, or air off. So I'm less likely to get some spray.
Yeah. Yeah, it's a great question, Chad. Oral surgeons use drills that are dedicated for this kind of thing. They're not doing crown prep, so their equipment tends to be a little bit more in line with what they're doing.
Yeah.
We will be getting some of that higher end equipment that can do more efficient bone cutting and what have you. But as far as crown lengthening, all of those things, I would just use an electric handpiece. I'm not going to tell you to use the chip air, but it's just not something I worry about. But if you're uncomfortable with it, you can turn off the air. The water then drips, and it's kind of messy. So I would have the assistant do what we do with implants and drip.
The saline.
Yeah, saline water out of a monoject syringe, if you're uncomfortable with it.
Gotcha.
I do it with the water air on the electric. I don't know, probably half the time anyway, because the surgical is not available. So I just get used to whatever with both. It works fine for me anyway.
Yeah, if anybody has any references on better guidelines with this, I'd love to hear it. But this topic has come up many times in many surgical courses, and the answer is always the same by very, very astute dentists. That's just stupid stuff they tell you in dental school. I'm only sharing the story. I try to be very clear on when I'm not qualified to provide an opinion. This is one of those times. With that said, I'm very comfortable with an electric and that little bit of chip air coming out. Now, I wouldn't use an air-driven without rear exhaust. That's kind of where I draw the line. With that said, if there's an article out there that provides more insight to this and we need better equipment to keep our patients safe, I'm all for it.
Last thing on handpieces that I ran into this with the cable electric. We ended up just buying a whole bunch of new ones because I think our Adec electric handpieces are going bad. Where the burr comes out, the neck of the handpiece dips down before it goes back up. Whereas the other ones where the burr comes out, the neck of the handpiece only goes up away from it. So just be cautious if you buy the cable ones, or check it out, because with it dipping down, it makes it really tough if someone's got long anterior teeth to do the right angles when you're
Right.
working on the posterior, because I just keep hitting the incisors each time.
Right. Huh. Yeah, I know what you're talking about. Have you ever tried... There's been times where I've been in the posterior where I will use a 45-degree angle surgical handpiece, electric handpiece. That'll get you out of the way. So
Okay.
upper second molars, I've done that. Because I know what you're saying.
I have used a 45 and I absolutely love it for those. It's like the whole handpiece covers your sight almost when you get really deep.
Right.
So having that 45 makes, I think, a huge difference.
Yeah. What about pedo handpieces? Anybody ever use a pedo handpiece for tough to open patients? That's another technique I've heard.
Do we have those?
I
don't think we do.
We did once upon a time, but they were... I think I bought an air turbine one just because I don't want to spend a lot of money on it if we weren't going to use it, and then nobody used it, so it found its way somewhere else. But if it's something we need, especially for kids, but it works great for TMD patients that don't open that wide. There are multiple uses for it. I've also seen, and I don't recommend this because it can ruin the handpiece, cutting the back end of a burr to make it shorter when you slide it in. But that changes the physics, the dynamics of the rotation of the burr, which can throw off the turbine. But seen that used too. All right, enough about handpieces. Hand grenades. What are hand grenades? Landmines. Who is Dr. Malapeti? The teeter-totter tooth, the Crco slide, and the number 18 crown impression. We can replace that with number 31. All right. This is a patient of Dr. Phillips. Him and I were talking about this last week, and I thought this was a great picture. Chantel is now taking this photo during our diagnostics appointment. So you can actually have the ability to classify their airway based upon this photo. Anybody want to take a stab at what Malapeti he is?
4.
Yeah, 4. So it's 1 to 4. Maybe he's a 3.95 because you can just barely see the top of the soft palate. But the Malapeti was an anesthesiologist, and this was a classification tool used to describe the complexity of intubation. So they get the young medical resident fresh out of school. They give them the Malapeti ones. It's easy to put the intubation tool in there. The hard ones they give to the 4th-year residents. So they came up with this classification tool. Well, we're not really interested in intubating anybody. Maybe those of us that do sedation, we need to know a little bit more about what that's like. But the purpose of this has to do with airway. As we spend more and more time together, I think we're all getting the realization that airway has a lot to do with everything that we do. The Malapeti score is helpful. So when Luke brings a patient to me and I'm like, hey, what's the Malapeti? He just knows that that's an important data point to bring up. And this is the hierarchy grading system that we use. Really not much to talk here other than that guy's got an airway problem. Potentially. He's at high risk because of how far down his soft palate is in relation to his tongue. This might seem like a little bit of a jump. We're segueing away from airway, but airway is always right there for us. I wanted to talk about Crco Slide. Mark is rather well versed in this arena. I'd love to hear what his thoughts are. And Mark, I promise you that some of the things I'm going to say is probably contrary to your education at Dawson or Pankey. You do Dawson or Pankey?
I've only done Pankey.
Pankey, okay. And they're very similar in their understanding of this world. They're nathologists at the end of the day. But I shared this here because most dentists don't understand whether they're ever in CR or CO. I think we all know that CR is this position where we take the mandible and we kind of shove it backwards. Most dentists, when they graduate dental school, have no idea how to do this well. That's where Pankey and Dawson come in. Those educational curriculums do a great job of, really making sure that we understand how to capture this record. Now, what's important is centric relation is a condylar position. Centric relation doesn't tell you where the teeth are. So I think we all know that. Centric relation is a condylar position. CO is the position of the teeth when the condyle is seated. Mark, that definition varies depending upon the school of thought. Am I on par so far with Pankey?
Yeah, for what they teach it, yeah.
Yeah. So centric
and they'll
occlusion.
address that it's changed over the years.
Sure, absolutely. Yeah. If you look in the Journal of Prosthodontic Terms, which is essentially the governing body for terms used in dentistry, the term centric relation has changed its definition based upon the position of the condyle in the fossa several times. So there's always the argument of where is centric relation, but we're always more interested, I would say more interested. The average restorative dentist is more interested in where the teeth come together. Well, where the teeth come together, we call MIP. So MIP is a term that says this is just where the most teeth contacts come together. MIP tells you nothing about the joint position. MIP and CO are often used interchangeably, but they're different, and that's not a topic for today. Just know there's all of these terms used to describe where the heck do teeth come together, and where's the joint when those teeth come together. What I wanted to bring up was the concept of the Crco slide. And there's the reason why I'm bringing this up here. This particular image uses the description of a mandible that is a condyle that is seated and the teeth have a class 1 relationship. They've removed the lateral incisors so that you can see the intercuspal relationship of the anterior teeth, or interincisal relationship of those teeth. But the point is, this is a class 1 occlusion. So for all intents and purposes, CR equals CO here. This is what Dawson, Pankey, and Spear would call an ideal occlusion.
Is it just me, or is that not class 1?
No, you are right. I guess I didn't. I just saw interdigitating teeth. Yeah, this is a class 3
It looks
setup.
nice, but then you're like, wait a second, something's off.
Yeah, something's way off. Yeah, I wasn't looking at the relationship. Wow. Thank you, Chad. You know, I just saw interdigitating teeth, and I saw CR equals CO, so I just assumed this is class 1. Picture these lower teeth, this cusp being where that fossa is right there. So the mesiobuccal cusp of the upper teeth should be pointing at the buccal groove of the lower first molar. This would be a class 2 setup, edge to edge. This is class 3. So yeah, this is just a really bad drawing. But the point is that CR equals CO when the teeth interdigitate properly. Now, you don't need class 1 to be in centric relation. You just need to have teeth that come together well and your condyle seated to actually to satisfy these requirements. We often try to aim for class 1 because there's reasons for that. But the CRCO slide is essentially a situation where the teeth come together ideally might actually be a position where the condyle is actually anterior to its centric relation position over here. So a lot of patients live with CO, not coincident with CR. So I'm going to get away from this image because it's a little bit erroneous. This one's a little better. Dr. Libby was talking about lateral cess. Lateral cess are tools used by orthodontists to get a better sense of where the bony structures are more than just where the teeth are. But I love this image because it showed here that centric relation might be in a different, the head of the condyle might be in a different position than centric occlusion. Okay, so they're different in most people. And the slide that exists between those is called the CRCO slide. So let's stay right here. Does anybody have any questions on that? Other than why is it important? I'm going to get to why it's important in a moment. Again, for redundancy purposes, CO is MIP. This is not related to that, but I had to bring this in order to keep the conversation going. Overjet is horizontal, overbite is vertical. These terms are used erroneously in the profession all too much. It's important to know these are two different things, and they don't happen simultaneously every time you see a patient. You might have a deep class 2 bite, that's an overbite. Meanwhile, you have a patient who's class 2 and they have a tongue thrust, they have a severe overjet. They're both class 2, they present differently with different problems. And sometimes they have a deep overbite and an overjet. Here's a picture of the joint, just to make the point that how the teeth come together is what dictates where this condyle is. I think we all know this. That's why when we do dentures, we're trying to provide a seated condyle in the anterior, most anterior posterior position, or anterior, depending on the definition that you subscribe to. This condyle lives up against the disc, up against the eminentia. That's how Dawson describes it. Here we have our envelope of function, or Poissol's envelope of, essentially, where does the mandible go? So these points represent an arbitrary point on the incisal edge of the anterior teeth, and these are the borders of where the mandible can go based upon structural borders of the head and neck. So the condyle only allows it to go in certain directions. The teeth are in the way for certain things. For example, this right here is our anterior guidance. This is our most protruded position. Here we have rotation of the mandible, and then rotation and translation as we come down here for maximum opening, so on and so forth. So this thing here is very important, but where I wanted to spend time talking about today is that. The CRCO slide is essentially the difference between these two small data points. Anybody have any thoughts on this up to this point? One might say this is only relevant for full mouth rehabs and dentures. Full mouth rehabs and dentures, you definitely need to know where you're going to put the mandible because you're choosing where in this envelope you're putting the teeth. Neuromuscular dentists may put it here. CR dentists put it here. Biological dentists may put it here. The everyday dentist works in this little spot here, but there are times when we deviate from that. We make a change in CO and we actually head in a different direction. And that's why I wanted to bring this up. The CRCO slide is a three-dimensional space at which, if and when we make changes, we can create other problems. Here are some other terms for this area or real estate of dentistry. CRCO slide, CRCO shift, horizontal freeway space. Orthodontists call it the functional shift. Dawson calls it long centric. Other nathologists call it freedom from centric. I put this in here. CR, when the teeth come together there. CO might actually be a little farther forward. So you can see there's lots of ways we can look at this, and it's all very important. I'm not going to spend much time on this. Let's go here. So this is why I brought this up. This is an image from Spear, the centric stop. Don't worry about these words here, protrusive gliding path, potential long centric. But I ask you the question, if that red line indicates where the muscles want the teeth to be, what are we going to see? So that's the thought-provoking question for tonight.
Wearing on the lingual surface.
Wearing on the lingual surface. So, Spear calls that pathway wear, so definitely. What else do we see?
And I guess attrition on the incisal edge as well.
Yep. So wear and attrition of the lingual surface of the maxillary incisors, commensurate wear to the incisal edges of the lower incisors. What else do we see? Because it's not always that. That's what's interesting. Some patients present with wear, other patients present with other things.
Let's see, facial pain or upper back pain.
Yeah.
This one.
Musculoskeletal imbalances. And that's the one that I really like to spend a lot of my time thinking about because it very much is connected. Looking at this image here, how did we get to the back? And that's a great answer, Mark. That's probably number one on the list of several. But how can, we're going to use the word entrapment. Entrapment is when there's tooth structure in the way for the ideal contact point of the muscles. So again, the muscles are controlling the mandible, but the mandible only closes where the upper teeth are. And if the muscles have different ideas on where they want the teeth to come together, problems arise. So when we have teeth that are in the way, we call that entrapment. Now some people, as they grow, they just wear away the enamel until their muscles are happy. Those are people with pathway wear. And those people very rarely, if ever, present with TMD. Those are your male patients with sleep apnea. But you get a lot of people where, they present with musculoskeletal imbalances, which is number one on the list. But number two is airway compromise. So we know that the tongue is attached to the mandible. If the mandible's just that little distance, a little farther back, that can close the airway enough to cause pathology. And that's something that might seem inconsequential, but I can promise you there's a lot of data to suggest 1 millimeter of horizontal entrapment can set the airway off into pathology. What about Fremitus? So we ever take our fingers and put them on 8 and 9 and we feel the teeth move? So patients who have slightly weaker periodontium, they may not have wear of the teeth because the teeth actually deflect when this happens, but they have Fremitus. And those people have no idea. But you get them equilibrated, you free them up here, and all of a sudden they say, I had no idea my jaw could feel so good. And it's because they weren't living with the ability for their lower jaw to close in that space. The neuromuscular world, they don't aim for this. Neuromuscular being LVI and similar organizations, they tend to open people up. And when they open them up, they actually get the muscles to an arc down here. So that's why when you see neuromuscular patients, they have these really long teeth. Well, they're satisfying the needs of the muscles, but they're violating the aesthetics in the process, which is one reason why I don't adopt neuromuscular concepts. But they often help patients tremendously. They just look funny in the process. We know through the world of ethology that if we provide what's called long centric, which is to actually equilibrate a little notch right here, that will actually give patients freedom. And that comes out of the Dawson Pankey world, which to me, creating a little notch that's highly unnatural is only trying to make the idea of centric relation being an endpoint, is trying to make it fit. And I very much digressing. I just think centric relation is a great concept to understand, but not something that we should be putting every patient into. And long centric is kind of the smoke to that fire. I think the answer is often ortho. Move these teeth to give the freedom that's needed, or restore them to that position where they have freedom from entrapment. And you get them to this point so that their mandible can live freely. And often when you do that, their airway improves at the same time. Their TMD improves, the aesthetics look better, and they have more reproducibility with their occlusion. So it's 8 o'clock. I had a lot more. We'll pick up next week. Anybody want to chime in? Does this make any sense? Is this relevant clinically? How do we make this actionable?
I know it's relevant to the patient that you showed the picture of.
Oh, that's true. Yeah, let's go to, this guy right here. So we talked about the piston tooth or the mortar and pestle tooth. So this is Chad's patient. When Chantel does the diagnostic photos, we have the patients tap, tap, tap so that we get a sense of where their occlusion's coming together. These are all entrapment. In other words, the mandible's kind of stuck. It wants to be more forward or more expanded. These blue marks are unfortunately showing us signs of entrapment. When patients are entrapped, their whole system's out of whack. They lose posterior teeth. They have neck problems. They're out of balance. All because of this little thing. So let's end on that. We'll pick up next week. Let this image be a provocation for some inquiry in your clinical execution.
Thank you.
All right.
Thanks, Doc. Good
See
night.
you guys.
Have a good night.